medicine channel. 60-year-old male, no commops, alleged history of trauma to head 3 weeks back. Came to ER with complaints of gradually progressive weakness of right upper limb and lower limb with gradually decrease in sensory.
Gradually means in how many days?
In 2 to 3 days.
2 to 3 days. Okay.
So initial 10 seconds assessment, airway was patent with no gargling of sounds, pooling of secretion, stridor, hoarseness of voice, breathing, respiratory rate of 24 per minute with a saturation of 98%, bilateral air entry present, circulation BP of 110/70 with a pulse rate of 80 per minute, all peripheral pulse palpable. Disability GCS was E3, V5, M6. Patient was drowsy but arousable, obeying commands. Then exposure.
GCS was?
E3, V5, M6.
Okay.
Then exposure temperature of 98.7 Fahrenheit with a GRBS of 150 milligram per dl.
Okay. So this is a patient, 60-year-old male without any commorbs, presented with decreased sensorium.
Sensorium and weakness of upper.
Weakness. And there is a positive history of trauma. So what do you think this patient might be having? And we have ruled out a few things in primary survey also. So excluding that, what do you think the patient might be having?
Since history of trauma is there, we are suspecting an intracranial bleed which can precipitate as weakness. So for that we did the CT brain. CT brain turns out to be an acute on chronic subdural hematoma with query active bleed on the left side of left frontotemporoparator area with a midline shift of 14 mm.
Okay. So basically, if this patient has because we suspect ICH because of the history of trauma. But if the history of trauma is not there, then the same weakness, the low GCS, the disorientation can be multiple causes. Can be infective, can be metabolic, can be encephalopathy related, or can be stroke. So basically, there are 2 types of stroke. What are the 2 types of stroke?
Hemorrhagic stroke and
ischemic stroke. Which is the most common one? Ischemic stroke is more common. More common in the sense 87% of the stroke cases are ischemic. And ischemic can be, it can be thrombotic, it can be embolic, and it can be hypoperfusion related, like in cardiac failure. And in case of hemorrhagic shock, what are the classification? Hemorrhagic stroke, what are the classification? It can be either intracerebral or it can be subarachnoid. Intracerebral constitute 2/3 of the ICH, and SAH, subarachnoid hemorrhage, constitute 1/3 of this thing. So if a patient presents with intracerebral hemorrhage, so what are the types that anyway for this patient we did the CT scan and we ruled out and we found that the patient is having an acute on chronic SDH. So what is SDH and what is EDH?
So SDH is a sudden, it is between a bleeding between arachnoid and the
subdural, beneath the dura
and arachnoid between. So it's mostly due to rupture of the bridging veins.
Weak cortical bridging veins. And this is more commonly seen in elderly people, in those in alcohol abuse, and very trivial trauma can lead to SDH.
In case of EDH, it is
what are the CT findings in an SDH?
SDH mostly a crescentic shape or semi-lunar, like
it is concavo-convex, that is the shape. Concavo-convex shape is seen in SDH, whereas when you compare it with an EDH,
it is biconvex.
It is biconvex, lens-shaped. So EDH happens due to?
Trauma. Most common trauma. Rupture of middle
meningeal artery. So one is an arterial bleed, the other is a venous bleed. Okay, so these are the main, and there are other types of bleeds also, but mainly because of trauma and all, we suspect either an SDH or an EDH. Okay, fine. And then?
Sample is.
Sample history, anything significant?
No, ma'am. Only history of a trauma. Coconut fell on his head 3 weeks back. But no history of any LOC, vomiting, syncope, retrograde amnesia. Nothing was there.
Nothing is there. So this patient has no comorbidities. Okay. But if a patient comes to you with an intracerebral, you suspect an intracerebral bleed, what are the things that you have to ask in history? Because intracerebral bleed intracranial hemorrhage can either be intracerebral or an SAH also, no? So what are the things in history that might, what are the risk factors that might be there?
On anticoagulant or antiplatelets.
On anticoagulant and hypertension. Most commonly, it is hypertensive vasculopathy. In hypertensive vasculopathy, all these penetrating arteries, that is, the arteries which join at right angles to the main vessels, they will be under pressure. So, they will rupture. So, normally, if it is a hypertensive bleed, there are certain areas where hypertensive bleed happens. Which are those areas? Normally in CT, we'll find
Gangliocapsule.
Mainly in pons, basal ganglia, putamen basically. Mainly they say that it is putamen bleed or thalamus or cerebellum or pons. These are the major areas of bleed that happens when it is patient is in hypertensive vasculopathy. If it is a cause. Other than that, what are the commonest cause? Amyloid angiopathy, cerebral amyloid angiopathy. But in cerebral amyloid angiopathy, all these small and medium-sized vessels, they get coated with some congophilic material, because of which the vessels becomes weak and they rupture. So this is normally it is more commonly seen in lobar hemorrhages. Lobar bleeds happen because of cerebral amyloid angiopathy. If it is not that, then what are the other things that can cause hemorrhage? What are the risk factors? Like it can be due to arteriovenous malformation, rupture can happen, or aneurysm rupture can happen, or simple cerebral venous thrombosis can cause any kind of tumors, brain tumors like high-grade gliomas, choriocarcinoma, melanoma. These and all can cause extensive lesions and which can further precipitate into bleed. And there can also be conditions where there is ischemic stroke with the hemorrhagic transformation, or post thrombolysis patient can undergo develop hemorrhage. So these are the things in history, and patient obviously who are on anticoagulants. Does antiplatelet drugs affect? In history, we'll anyway ask for medication, no? So what are the most common anticoagulant which can result in bleed?
Apixaban.
No, warfarin. Warfarin is the most common. Then it comes DOACs, direct oral anticoagulants. Direct oral anticoagulants are apixaban, rivaroxaban, dabigatran, etc. And there can also be heparin also can induce. Very rarely antiplatelets induce this bleed. So these are the things that you have to ask in history. And in case of SAH, if you talk about subarachnoid hemorrhage, then you have to ask for that classical, what is that classical symptom? Headache, the thunderclap headache. So they say that there is an Ottawa subarachnoid hemorrhage rule. There are a few points in that. Like if the patient had presented with a thunderclap headache, or if the patient is having neck stiffness, neck pain, neck stiffness, or if this happened during exertion, there are certain points. So if they satisfy at least one of the points, then we have to mandatorily rule out SAH. So that is a rule. And even in SAH, you will have to, there is a grading also. What is the name? Grading, SAH grading, Hunt and Hess. Hunt and Hess grading is also there in SAH. So these are the things in history that you can suggest, which indicate that the patient can have an intracerebral hemorrhage. So this patient has an SDH, which we diagnose by CT. So what is, as emergency physicians, what is our approach to this patient?
Our approach is to first thing is to, if there is edema, we can control edema or hypertension. If the patient's BP
no, as emergency physicians, what will be our airway breathing? First is stabilization. Airway breathing, circulation, we have to stabilize. If the patient is having decreased sensorium, if you feel that the patient cannot maintain his airway, obviously airway has to be secured. And same similar, just like we see, airway breathing and circulation has to be maintained initially. That is the first and foremost thing. So in this patient, the bleed has already occurred. But if patients with ischemic stroke, we can thrombolize and you can revert the condition. We can try to at least revert the condition. So in this case, the bleeding has already occurred. So what are our main priority during our treatment? Because main management of SDH, if they have to surgically evacuate, that is by the neurosurgery team. But we as emergency physician, what should we think when we manage an SDH? Other than this, after we have stabilized the patient, after stabilization, what should be our what should we keep in mind? BP control. Why BP control?
More chance of bleeding.
Hypertension can cause increased bleed. What about hypotension?
Perfusion,
Decrease cerebral perfusion can cause hypotension, hypoperfusion also. We have to maintain BP. So is there any target blood pressure that we have to maintain?
More than 85. Like 65 to 80.
MAP has to be maintained. But at what condition if we'll start an antihypertensive? Where are the conditions where means in what BP you will start an antihypertensive?
Have to maintain
systolic blood pressure more than 150 or a MAP if it is more than 130. In this condition, we have to start an antihypertensive. What are the antihypertensive that we start? Labetalol. If labetalol is not there, then nicardipine, clinidipine. These are the things that we give. That is if the systolic blood pressure is more than 150. But if it is more than 200, 220, then you can't keep on giving bolus. No, so you'll have to start infusion. So if the systolic blood pressure is more than 220, we'll have to start infusion of antihypertensives like labetalol, nicardipine, 5 milligram per hour and all. Infusion has to be started. Otherwise, you can maintain the blood pressure by giving normal. You can give antihypertensives as boluses. So this is the thing regarding BP. So first thing is to prevent the hemorrhage from expansion. You have to control your hypertension. Then what are the things to control? What is the main thing that you see in a patient with SDH? We see certain, what is Cushing's triad? You see,
bradycardia, hypertension with altered breathing.
Bradycardia, hypertension and respiratory irregularity, altered breathing. What happens to the brain due to hematoma? If there is a bleed, what happens to the brain? What are we trying to prevent? Herniation also.
Secondary brain.
Because this hematoma itself can cause some perilesional edema. So this will cause mass effect. When mass effect results, there will be increase in intracerebral pressure, which in turn will reduce the cerebral perfusion. So basically that is primary injury that happens in a bleed. There is secondary injury because of this hemorrhage. There it will produce some inflammatory mediators which will disrupt the blood-brain barrier. So for that also, so our concern has to be to prevent the secondary brain damage also in a patient with SDH. So first thing we did is to maintain we stabilized the patient, we maintained BP, antihypertensives we started. Second thing is to monitor intracranial pressure. What are the signs that say that the patient is having decreased ICP? Yeah, abnormal ICP. There are certain signs, like symptoms which suggest deranged ICP.
Vomiting.
Anisocoria, vomiting, irritability, headache, any pupil changes can be anisocoria, decreased reactivity of pupil, papilledema in fundus. Cushing's triad is a complication. Brainstem involvement can be there. All these things suggest a raised intracranial pressure. So what are the things that we have to do in order to decrease the intracranial pressure? We do certain things in patients, What do we do to decrease an ICP in a patient with bleed?
We can do anti-edema.
Anti-edema measures. What are the anti-edema measures?
3%.
Other than that, they start from positioning. Head and elevation. Elevate the head end to 30 degree. You manage the patient's pain. If he is having vomiting sensation, manage vomiting. If the patient is having seizure, give seizure. That is again a problem. Do you give patients anti-seizure medication in a patient with bleed? Anti-seizure medication, is it indicated to be given in a patient with bleed? Because ultimately mass effect and all, sometimes it can cause seizure, no? So prophylactically, do you give anti-seizure medication?
We have to.
Actually, they say that 13% of patients only develop seizure. Out of intracranial bleed, only 13% of patients develop seizure. So when you look at the risk versus benefit ratio, the risk of giving an antihypertensive is more. So you give antihypertensive only in patients who are having either clinically they are having seizure or in EEG. Non-convulsive status epilepticus cases, you give anti-seizure. Otherwise, it is not at all recommended to give an anti-seizure medication. Okay, so that seizure is there then. So ICP reducing, you give anti-seizure medication. If the patient is intubated, you have to keep the patient in block, neuromuscular block. Sedation, what is the thing that can help? There are a lot of sedatives that we use, no? This phenobarbital and all helps. Why? They will reduce the cerebral metabolic rate. So that and all will help in patients with ICP, raised intracranial pressure. Then comes to drugs. Drugs like mannitol, 3% hypertonic saline, manners like hyperventilation that can wash out the carbon dioxide, that will cause vasoconstriction, decrease cerebral blood flow and decrease the ICP. So these are the things that we have to do in ICP in order to lower the ICP. What is normal ICP? Normal intracranial
6 to
pressure.
15.
5 to 15 millimeter mercury. So if it is more than 20, you will have to do surgical management. What are the clinical signs that you see in a patient and you do a CT, you find that patient is having bleed? So you have to inform to the neurosurgeon, no? In some cases you can wait. You can stabilize and then inform. But in some cases, you will have to inform urgent. So that urgent neurosurgical consultation is given in what cases? What do you see in that patient to say that you will have to call the neurosurgery now? What are the things like that? Yeah, brainstem compression. What about SDH? At least 10 millimeter SDH or more than 10 mm, or if the midline shift is more than 5 mm, you have to inform urgently. Or if there are conditions like he said, brainstem compression or any herniation symptoms and all are there, or you can see it in the CT, then that you have to call. Or if there is a very obvious GCS drop in GCS, if you see more than 2 drop is there, patient is clinically very badly deteriorating, then you can see, then you have to call. Next is CT. What is the investigation of choice? It is CT. CT you do. What do you see in CT? What is the CT finding in a bleed?
It
Hyperdense. Hyperdense. Depends on the time. If it is
acute, it's hyperdense. It's subacute, it's isodense. And if chronic, it is hypodense.
Hypodense. That is it. What about MRI? What is the MRI also? It is the same thing. There is subacute, there is acute, there is hyperacute, and there is chronic. Hyperacute is within 3 hours. So in hyperacute, the thing that we see is because of oxyhemoglobin. So in MRI, T1 and T2 weighted imaging, T1 weighted imaging will be hyper intense. You can see the lesion hyper intense, and T2 will be hypo intense. So then is acute. Acute is between 3 hours to 3 days. So where deoxyhemoglobin comes up. So when deoxyhemoglobin is having very more magnetic property than oxyhemoglobin. So in T1 and in T2 weighted images, it becomes hypodense. Hypointense, sorry, not hypointense. And when it comes to subacute occurs in a condition after 3 days. After 3 days to 3 weeks and all, it is subacute bleed. You call it subacute. So in subacute, the MRI picture reverses. Like in T1, it will become hypointense. In T2, initially for the first 1 week, it will be hyperintense. Later, it becomes hypointense. Chronic is more than 3 weeks. That you will see as hypointense lesions in MRI. What is what do you call this? What do you say? CT spot sign. There is a spot sign in CT. Not normal CT, only in CT angiography you can see a spot sign. What is spot sign? You can see a spot in a hemorrhage. You can see a hemorrhage, you can see a spot which is bright. That suggests that the hematoma is expanding. So it suggests that the patient is having very bad prognosis. So that spot sign, some people say that if the number of spots focuses more, multifocal and all, the chance of deterioration is very high. So if a patient comes with a chronic bleed and in CT angiography you find a spot sign, it suggests that the patient is having very bad prognosis. So that is the MRI features. Edema can be seen in CT. Yes. Edema can be seen in CT. It will persist also. 7 days, 10 days, you can see the edema becomes very prominent in 24 to 48 hours. It can last also till 7 days. So that is imaging. We talked about BP monitoring. We talked about ICP monitoring. You have to reduce all these, in order to reduce secondary brain injury, you have to reduce hypothermia, hyperthermia, you have to treat hyperglycemia have to be treated. These and all are the parameters that has to be treated in order to prevent the secondary brain injury. One more thing, if the patient is on anticoagulant, should we give a reversal in patients with bleed?
Yes.
Yes. Oh, how do we give a reversal? If patient is on warfarin, how do you give a reversal?
Vitamin K.
Vitamin K. But only vitamin K will help. Why not vitamin K? What is the problem with vitamin K?
Take time.
It will take very long time. For it to act, it start action only after 2 hours. The proper action comes at 6 to 8 hours. So that is vitamin K. You give at least 5 to 10 milligrams IV you give. If not, second, FFP. Fresh frozen plasma can be given, or main thing that you give is PCC, prothrombin complex concentrate. There is 3-factor PCC, there is 4-factor PCC. 3-factor is factor 2, 9 and 10. 4-factor is 2, 7, 9, 10. This you have to give 50 international units per kg. That is 4-factor PCC can be given. These both vitamin K and PCC act synergistically. It's same action but faster onset of PCC. Okay, so that is warfarin. If the patient is taking heparin, then
Protamine sulfate.
Protamine. What is the dose? Before giving protamine, what should we do? What is protamine? Protamine is a thing that you get from fish sperm. So it is very prone to allergy. So whenever before giving protamine, normally we give hydrocortisone before giving because it is very prone to allergic reaction. So protamine, what you give in both unfractionated and low molecular weight heparin?
No,
We give in both. We give in both, but dose is different. In case of heparin, you have to measure the dose of heparin you took in last 3 hours. And that dose, for every 100, you have to give 1 milligram protamine. That is a dose. You have to calculate the dose and give maximum you give up to 50 mg. But if it is low molecular weight heparin, what do you see? You have to see the dose in if the patient has taken low molecular weight heparin in the last 8 hours. If he has taken in 8 hours, 1 milligram of low molecular weight heparin, for that you have to give 1 milligram protamine sulfate. If the patient has taken it in 8 to 12 hours, within 8 hours, 1 milligram equal to 1 milligram protamine. If it is 8 to 12 hours, 1 milligram is 0.5 milligram of protamine sulfate. And if it is more than 12 hours, you don't have to give protamine sulfate. So that is anyway, if it is both unfractionated as well as low molecular weight heparin, you have to give protamine. And the other thing, if it is dabigatran and all, there is a drug, no? No, there is idaracizumab drug. Drug is there, 5 gram you can give IV. That is basically for which drug? It reverses one drug out of all, dabigatran. It is for that. And you can give anti-sanat alpha, you can give FFP and all you can give. Antiplatelet, in patients who are taking antiplatelet, do we reverse? we don't reverse. We don't reverse normally. Why? Because it can cause arterial and coronary thrombus, which can further worsen the patient's situation. So antiplatelet we don't give reversal, anticoagulants we give reversal. So basically these are the things that has to be kept in mind when you deal with a patient with bleed. First we have to identify the bleed, we have to identify the danger signs, we have to and we have to give a neurosurgery consultation if he requires emergency surgery. Second is we have to manage the primary and secondary brain injuries. We have to stabilize the patient, we have to manage the hypertension, we have to manage the ICP, and we have to, if the patient is on anticoagulant, we have to reverse the anticoagulation. So these are the major steps in management. Rest you can read upon.
Thank you.